right. Thanks very much, George, and thank you to Glenda, and thank you to the Aspen Institute for this wonderful invitation to this exciting meeting. This has been great. I want to talk to you today about something very different. And first of all, let me ask, how many people here would like to avoid Alzheimer's disease? Yeah, me too. Okay. And let me ask, how many people here have had a colonoscopy? Most of the people in the room have had a colonoscopy. Good for you. You did the right thing. How many people here have had a cognoscopy? Okay. So just as George was saying, we need to prevent this illness, which is going to bankrupt Medicare. You've heard some remarkable figures, unfortunately all of which are true, about what's going to happen to us going forward. About 15% of our population, as Glenda said earlier, will unfortunately develop Alzheimer's if we don't do something about it. So what I want to talk to you about today is what happens when you look under the hood. So we've had the lab up for 30 years now, and very simple question for 30 years, which was, could we understand the phenomenon of neurodegeneration, what actually happens at the molecular level, in enough detail that we could ultimately begin to fashion the first effective treatments. So let's go to the next here. So imagine now that you went in, you took your car in, it's not working very well, and the mechanic said to you, oh yeah, we recognize this, we see it all the time, this is car not working syndrome. And you said, well, wait a minute, and they said, yeah, older cars, it's common, it's not working well. And you say, well, would you like to do some tests? He said, oh, there's nothing that can fix it, we don't know what causes it, there's nothing that can fix it. And you say, well, could you do some tests, check a few things? Well, no, those tests aren't reimbursed. We don't do those tests. This is the problem we have had, and I do think in the future we are going to look back on the immediately preceding era as the dark ages of Alzheimer's disease. If you go to an Alzheimer's center today, you will not be told why you have Alzheimer's disease. We say, we don't know where it comes from. And in fact, there is a fundamental medical revolution taking place. And of course, you're going to hear from Mark Hyman, who's one of the chief architects of this medical revolution. And if you look back to 20th century medicine, the way I was trained when I went to medical school, it was all about what it is. Is it Alzheimer's? Is it Parkinson's? Is it heart failure? That's what we were taught to figure out. 21st century medicine is fundamentally different. It is about why it is. And if you look at all the contributors, why did you get this problem? Why do you have cognitive decline? Why do you have hypertension? If you go into your doctor today and the doctor tells you you have hypertension, what's the chance he's going to tell you why you have hypertension? And what's the chance he or she is going to write you a prescription for an antihypertensive? This is what needs to change. We are dying now from illnesses that we weren't typically dying from 100 years ago. In the 20th century, of course, many of us, especially in the first half of it, were dying of simple acute illnesses, pneumococcal pneumonia, tuberculosis, things like that. And we had a very good strategy. You wait for the symptoms to come on, you get the drug, you get better. In the 21st century, almost all of us are dying of complex chronic illnesses, from Alzheimer's to cancer to cardiovascular disease, things like that. These things are not typically caused by one agent. Therefore, writing a prescription does not work very well. We need to understand for each case why this happens. Okay, so how many people know about the Ansari X Prize? You remember the X Prize? So there are X Prizes for a number of things now, but the original one was the Ansari X Prize. And what this was about was that you wanted to be able to, and this was the challenge, to put a man into space twice within 1 week, so it's commercial space flight. And interestingly, the engineer who developed the answer, the one that ultimately worked, made a very interesting point. There was no ability to do this when he started, and he realized anything that was going to work was going to be outside the box. So his point was, any idea that we came up with to get the person out and then bring him back commercially twice within a week was going to be something that people would say is crazy, because he said anything that was inside the box, we already know doesn't work. So whatever the answer is going to be something that when the first person thinks of it is going to sound crazy. And that is what's happening in developing treatments for illnesses that have been untreatable. So interestingly, what he came up with was a spacecraft that actually could change shape dramatically while it is in space. Sounded crazy, it's the thing that ultimately got the prize. So we have a sad state of affairs, as you know right now, in Alzheimer's. Patients wait way too long because they know that there's nothing that can be done. They finally go into their primary care provider. The primary care provider then says, well, look, I don't need to send you to a specialist because I can write a prescription for Aricept. It doesn't work very well. They write the prescription. So the problem is that they wait finally to get to a center. Finally, when they're very late in the process, they go into a specialist. And what does the specialist tell them? Number one, we're going to make sure you don't have a driver's license. Number two, we're going to make sure you can't get long-term care insurance. Once it says memory problems on your chart, you cannot get long-term care insurance. And look, there's nothing I can do to help you, but would you mind coming back every 6 months so I can do a spinal tap on you and renew my grant? That's how bad things are at the best centers. And let me show you an example here. This is from what is recognized as one of the most outstanding centers in the country. I won't mention which one, but this is from a real patient, MRI of the brain, blood for complete blood count, metabolic panel. I asked the patient and his wife to keep an eye on his disabilities. I prescribed donepezil 5 milligrams. Okay, here's what the person did not do. And this is at one of the best Alzheimer's centers. This is the gold standard of the gold standard. No genetics. Didn't ask whether this person was ApoE4 positive, which is the most common risk factor for Alzheimer's, genetic risk factor. TREM2, CD33, on and on, all the genetic markers. None of them were checked. Nothing about CRP. How many people here know their HS-CRP? Okay, so maybe about 10 people. So it is related to the inflammation we heard about today. Nothing about interleukin-6 or anything about whether this person actually had any inflammatory process going on that may have been contributing to his possible Alzheimer's. Nothing about homocysteine. How many people know their homocysteine? Okay, a number of people. Related to methylation, related to detoxification, and a number of things, including how rapidly your brain atrophies. Nothing about fasting insulin. How many people know they're fasting insulin? Yeah, good thing, and as Mark Hyman has pointed out, we'd like to see it at 5 or less. And so many people walking around with very high fasting insulins. This, again, is a risk factor for Alzheimer's disease and something that can be modified. Nothing about hormonal status, nothing on toxin exposure, nothing about the status of the innate immune system, which is what drives the amyloid that is produced in Alzheimer's that George mentioned a few minutes ago, is produced as part of the innate immune system's response. Nothing on gut health. We've heard so much about gut health, wasn't even checked. Nothing on microbiome, nothing on blood-brain barrier. Prescribing donepezil without a diagnosis. This person's BMI was 33, so this person was about 50 to 60 pounds overweight. Wasn't even mentioned. It was as if the head is cut off from the rest of the body. No plans to address this. And then this person happened to have prediabetes, again, a key risk factor, nothing to address that. So this is the gold standard workup in our best centers today. This has got to change. We've got to address this in a different way, just as the Ansari X Prize had to create a satellite, literally, that would change shape. So here's the current standard. One cause, we don't know what the cause is, it's Alzheimer's. One disease, Alzheimer's disease. One treatment, it's a monotherapy, and as you already heard, it's ineffective. Here's what the research says, and we've had the lab up, as I said, for 30 years looking at what actually drives these problems. There are at least 36 different contributors that we've identified, and there are probably a few more, but there are probably not thousands, but there are dozens. There are 6 subtypes of this. This is not one disease, it's subtypes, and you can figure out which subtypes you're dealing with. And often people will have combinations of those. And there are many treatments. This is a personalized program. Each person needs to be dealt with differently. And so in 2014, we reported in a peer-reviewed journal the first examples of reversal of cognitive decline. And of course, not surprisingly, there's all sorts of pushback. How dare you say this? These people didn't have Alzheimer's. So we're now publishing 50 more who have very well-documented improvement and very well-documented Alzheimer's disease. Let me show you a few of the first survivors of Alzheimer's disease. So here's a guy, he's actually now 74, ApoE4 positive, very typical story. Already had a PET scan, typical of Alzheimer's disease. You essentially get two L's, temporoparietal reduction in glucose utilization in your brain. Neuropsych testing showed that he was declining. You can see down to the 3rd percentile here, unable to remember lock combination, faces, schedule, difficulty at work, difficulty with numbers. He had been able to add numbers very quickly in his head. So he had early Alzheimer's disease. He improved within 6 months. Interestingly, his wife called me and said, you know, you missed the most important thing. I said, what do you mean? And she said, well, he was actually increasing, accelerating in his decline, which is a common thing. So after 2 years, he was much, much better. We asked him to go back and get his neuropsych testing once again, and you can see here the dramatic improvement. He didn't want to go back. He said, look, I know I'm doing well, my wife knows I'm doing well, my coworkers know I'm doing well. The last thing I want to do is have the neuropsychologist, who's always been kind of negative, say, look, you are doing poorly. Well, you can see here just dramatic improvements in his quantitative scores. For example, his auditory delayed memory from 13th percentile to 79th percentile. So this person is now 4.5 years out. The longest we have are a little over 6 years out, and he's doing very, very well. Here's another person who came actually to see me at UCLA in 2014. Family history, both parents died with dementia, very well documented. This guy is a brilliant physician himself. ApoE4 positive, amyloid PET markedly positive, FDG PET typical for Alzheimer's, hippocampal volume reduced. Neuropsych testing showed that he was already well into MCI. His hsCRP was high, so he had an inflammatory state. His homocysteine, much higher than it should be. His vitamin D, too low. His testosterone was low as well, his free T3. So he had many contributors. He responded beautifully, metabolically, cognitively, volumetrically to what we call ReCODE, which is an algorithm that we developed for this. His neurologist says he's normal, and here he went back, and you can see here, his hippocampal volume went from 17th percentile to 75th percentile. And we heard earlier beautiful work about stem cells and their relationship to the hippocampus and to the brain. So he responded. In fact, interestingly, the neuroradiologist would not believe this. He said, we simply don't see this. You can't see the brain grow like this. So of course we got the films, took them to another computer-based algorithm that showed that yes, this guy had increased his hippocampal volume. And he's still doing very, very well at this point. You can see here his gray matter volume increased by 23% itself. So he's doing very, very well. So just to encapsulate 30 years of lab bench research into just a couple of minutes, let me show you what we found from all this research. What we found is that these chronic illnesses are really signaling imbalances where many things feed into this. So if you have osteoporosis, your osteoblastic signaling, all the things that contribute to making bone, are chronically outstripped by your osteoclastic. These are the ones that are reorganizing the bone. If you have cancer, your cytoblastic signaling, making more cells, unfortunately, outstrips your cytoclastic, the turnover of the cells. And if you have Alzheimer's disease, in fact, what we found is that all of the things that contribute to making synapses and keeping memories are outstripped chronically by all the signals that are reorganizing. So you are literally downsizing. What we call Alzheimer's, and here's the big surprise, what we call Alzheimer's disease is actually a protective response to 4 fundamentally different classes of insults. So for each person, we need to identify what those insults are. And you can see this straight at the molecular level. You can see amyloid precursor protein, which is its molecule in the middle here. It can be cut in 2 different ways. If it's cut at one site, you get 2 peptides that support, guess what? Making new memories, growth of neurites. They are part of making and increasing your cognitive abilities. The same molecule, however, can be cleaved at 3 alternative sites to make 4 peptides that do just the opposite. They are pulling back. This is no different, by the way, than what would happen, for example, if you have a country and you've got now invaders coming in. What do? You're going to put down napalm. A beta is like napalm. You are putting down things that actually will damage the intruders. And some beautiful work from Robert Moyer and Rudy Tanzi at Harvard showed that amyloid beta is quite a nice endogenous antimicrobial. We had found a couple of years before that in fact it also is involved with downsizing. So if you don't have enough trophic support, if you don't have enough of these various factors, you downsize and you use the napalm approach to kill, whether it's bacteria, whether it's fungi, whether it's viruses, or whether it's just that you don't have enough nerve growth factor, brain-derived neurotrophic factor, testosterone, estradiol. You can just go right down the list. If you cannot support your wonderful network, you need to downsize. Okay, so in a mouse, we can do this easily because we know how we gave the mouse Alzheimer's. But in a human, what are the things we need to do? Well, unfortunately, it's a lot of them. There are a lot of things that actually contribute. That's why we say 36 holes in the roof. You've got to plug them all. What that means is that if you want to develop a perfect Alzheimer's drug, this is what it will have to do. And this is why it is going to be very difficult to take one drug. Now, this doesn't mean drugs are unimportant. They're extremely important, but they're very good patches for one hole. You need to identify the other holes and address them if you're going to get an optimal result. So, as I say, we tell the patients, you've got a roof with 36 holes. We need to measure and identify all of these. And we need to produce a new kind of physician. And this is where Mark Hyman's work has been so important over the years. If you look at the traditional Chinese physicians or the Ayurvedic physicians, for example, what do you have? You have physicians that get that there's a whole body there that you need to identify and treat all of these things. But they don't know about things like microRNAs and DNA and whole genomes. The 20th century physicians know about those things but don't know and aren't treating the whole body together. So we need to train a new kind of physician, right? That understands, that uses the latest technology, but understands that this all works together. So in summary, Alzheimer's should actually be, and can be, a rare disease. In fact, it should decrease dramatically with this generation. What is referred to as Alzheimer's, as I said, is the result of a protective response. Inflammatory things, whatever the organism may be, glycotoxicity, literally insulin resistance, trophic withdrawal. If you don't have enough support to keep up your brain network, you're going to downsize it, just like a company. And then specific toxins, and doctors have not been checking for these things in people with cognitive decline. There are 4 major subtypes and combinations, and you can see which these are by looking at the metabolic and genetic profiling. Next, cognitive decline in early Alzheimer's disease and its forerunners, MCI and SCI, is reversible. We've seen many patients now who have reversed this. As I say, we're publishing another 50. This programmatic approach should be applicable to other diseases, so we're starting to work with people. So here's a question for you. What is a more common neurodegenerative disease than Alzheimer's disease? The answer is macular degeneration. There are about 11 million people in the United States currently with macular degeneration. We're starting to work with patients with that as well. So we should be able to identify the causes of these various chronic neurodegenerative conditions. As you know, this has been the area of greatest biomedical therapeutic failure. It used to be said, everybody knows a cancer survivor, nobody knows an Alzheimer's survivor. And so we're now beginning to see the first ones. So we should be able to reduce the global burden of dementia markedly and chronic illness burden and increase global cognitive ability through metabolic profiling, larger data sets, prevention and early reversal, patient researcher partnerships, and personalized programmatic approaches to cognitive and overall health. This is the way of the future. And much like the X Prize, we need to look at this differently. We need to look at healthcare differently. It's the old idea of wait till you have symptoms, come in, get a drug. It does not work well. It's not the optimal approach for complex chronic illnesses, and we're seeing this again and again and again. So we look forward to a world that has much less dementia.